So here are some strange rectal cases. Start with this one. So we have a lot of Mets, and we go down, and we already know the theme today. So there's this hypervascular mass kind of in the mid-rectum. So when we see these hypervascular masses, I guess there's always this differential, and this does turn out to be a neuroendocrine tumor. So these are 25% of gastropancreatic neuroendocrine tumors, and this patient was also in his 50s. They're usually small. This one was pretty large, and most in the mid-rectum, about 5 to 10 centimeters from the anal verge. So something that we don't see as common, but to put in the back of your mind. Here is another.
Wait, Victor, I have a comment about your last case.
Yep.
I like your, so the rectal neuroendocrine tumors, they can also often be incidentally found. So a lot of people
Yes.
are getting colonoscopies will get a polyp, and maybe it's like a very, very tiny polyp, and it comes back neuroendocrine tumor. And those ones, they basically don't do anything for, they don't even do surveillance afterwards, and they don't do, screening of the liver or anything like that. So often these rectal neuroendocrines can even be a tiny incidental thing. This one obviously was a huge one.
That's exactly right. Yeah, most of these, the 5-year survival for these tumors is really high. And it's similar to the appendiceal neuroendocrine tumor, usually found incidentally, often on appendectomy, and those patients usually have no clinical sequelae related to that tumor. Okay. So here's another rectal mass. This, let's see. So I think the rest of the scan looks pretty good. This may have been the CT for a PET scan. We see this well circumscribed mass here, in the rectum. Any thoughts? Maybe a little exophytic.
Oh, great. Kedar is guessing a GIST tumor.
Right. So this was biopsied as a spindle cell neoplasm, and findings were suspicious for a GIST. And so this is a rectal GIST. It's usually large, eccentric masses, oval or round, growing beyond the rectal wall, but with well-defined margins, as in this case. And most have this exophytic growth patterns like other GISTs. And there's the mimic for anterior rectal wall GIST that can sometimes mimic prostatic tumors, so we have to be aware of that. And in the literature, most of these demonstrate heterogeneous enhancement with internal necrosis and hemorrhage, even though the case that I just showed you is relatively homogeneous. Okay, so this is a 74-year-old man. He was a retired radiologist, had a normal colonoscopy 1 year ago, and we can see a large metastasis in the liver with this tumor that's just above the anal verge. So
I would have thought maybe the liver was like a primary, and then the thing in the pelvis was like a drop med or something. It seems so out of proportion.
Yeah, that's true. That's a good thought. In fact, for most of these, we do have to be aware that since these are so uncommon, that the finding in the rectum could be, metastasis and not the primary tumor. But this is more commonly a skin malignancy. This ends up being a malignant melanoma of the rectum. And these are rare, 1% of melanomas. And so, yeah, we do have to exclude a metastatic implant from primary melanoma. Usually they're in the distal rectum, just above the anal verge, and polypoid or fungating.
Okay, Victor, I'm gonna keep challenging you.
Yeah.
How do you know if they could truly tell that this was, the primary was from the rectum, or maybe both of these are mets from somewhere else, or do you know if they can tell that?
I don't think they had a primary skin melanoma, which is why they thought it was a rectal melanoma. But, oops, did that show up? Hope not.
No, nothing showed up.
Okay, great, because my PACS is logging me out, and
okay.
So yeah, if you exclude a skin melanoma, then then usually, try
But
to
they
find.
can be from like, you can get ocular melanoma, vaginal melanoma. They can be from other.
Yeah, that's probably also more likely, but this patient was given the rectal melanoma diagnosis.
Okay.
Yeah. Here's a CT colonography that Cine I wasn't able to get to load. So here are 3 static images from top to bottom. And this is the uterus. So she has a history of sarcoid, and I guess because this looks like some weird calcified intraluminal colonic mass, we suggested as one of the differentials, could it be related to that? But it'd be kind of unusual. So what we didn't really think about was this person also had a history of myomectomy, and this is really kind of just above the uterus. So any thoughts as to what this could be given that history?
And a fibroid that's invaginated into the colon.
Yeah, that's the thought, and what ended up showing up on endoscopy was this hard calcified mass, which probably was from prior surgery, but this was resected and it's thought to be just surgical material. So it's a suture material and a strip of plastic material was what they found, probably from prior myomectomy. All right, that's an interesting one. Okay, so 2 more cases here. Here's a restaging PET CT. And its history of breast cancer.
So it looks like a bunch of perirectal nodules and masses.
That's the finding here. So this went to excision actually, and was a retrorectal cystic hamartoma. So it looked kind of ugly, but this is a classic location and one of the common appearances.
And I probably an MR, I guess, I don't know. Do you think that in retrospect, like if we had recommended an MRI, it would have helped to show the cystic nature of it?
I think it would show the cystic nature, but these look like they're variable density, and MR would probably still show heterogeneity of these different locules. And to be confident about diagnosis, these usually go to biopsy, and as I'll show in a later slide, excision is also recommended. So yes, an MRI could help show
There was
that.
a question saying that there was a follow-up PET CT, and did this change? Did the lesion change in the interval between this scan and the PET CT?
Actually, don't. I think this did not change. Yeah, I think.
Oh, I think they were saying this was a restaging PET CT. So, for example, did this change from the prior one? So,
Yeah,
I guess that
yeah.
would have been, and actually, probably a retrorectal cyst might not have been that FDG avid,
Right.
which would go against METs. So, yeah, I guess we can always think about if we see a retrorectal mass, these retrorectal cysts or tailgut cysts are common, and then an MRI would maybe show it more being cystic, and then we'd be like, okay, well, more in the retrorectal cyst differential than in METs, maybe.
Correct. Yes, that's right. And here is another example, actually. So this was to rule out diverticulitis, and we saw this mass. And it almost looks like it's solid. So we suggested it could be this, or it could be a tumor. And this also went to biopsy. So they found fragments of disorganized smooth muscle, squamous epithelium, most consistent with a tailgut cyst. And I guess the pathologist noted that this was somewhat challenging that the findings are nonspecific, but together with the clinical history, uh, that they concluded this is most likely a tailgut cyst, and there are no features of GIST, but that given the risk of malignant transformation, these are usually excised. So these are also known as tailgut duplication cyst, usually in patients 30 to 60 years of age, like in both of these examples, and most are instantly found, like in both of these examples that I've shown. And imaging-wise, you'd see a multiloculated retrorectal cystic mass, and it could be water or soft tissue density, usually excised. All right, that is all I have.